And welcome back. Thank you, everyone, for your promptness and returning from the break. We're going to move on to the next segment of our agenda, the state of the science. What do the data say? We had an excellent overview from Dr. Marazzo from NIH to talk a little bit about the research perspective and where we are. But this panel will dive a bit deeper. And so I'm excited to hear us from some critical partners and colleagues in the work. This panel will be co-facilitated by our own PACHA member, Tori Cooper, who serves as co-chair for the Ending the HIV Epidemic Subcommittee, and Dr. Hansel Tukes, PACHA member and liaison to the CDC HRSA Advisory Committee. We will be able to take questions and comments from members and federal partners around the table before we break for lunch. So it is now my pleasure to turn the floor over to Tori and Dr. Tukes.
Thank you so much, Marlene, and to the people who were in the room from our site visits yesterday, thank you so much for your gracious hosting of us. I have the distinct honor of hosting this panel with the legendary legend, Tori Cooper. It is my first hosting of a panel at PACHA. Really excited. We're going to get right to the presentations this morning, starting with Stacy Cohen. She is Acting Associate Director of the Office of Performance Improvement at the Division of HIV Prevention at the Centers for Disease Control, and she is going to set the stage with the hot off the press new CDC HIV surveillance data. So with that, Stacy.
Thank you. As Hansel mentioned, my name is Stacy Cohen. I'm actually officially the Associate Director of the Office of Performance Improvement as of 2 weeks ago. Thank you. So thank you for having me here today to kick us off in this session about what the data say about the state of the science. What am I doing wrong? Okay, got it. So we wanted to start the panel off by providing an overview of the recently released surveillance data, and the panel agreed that we also needed to start with a reminder about the importance of seamless prevention and care, including support services to ensure success. And success across the prevention and care continuum is dependent upon strong partnerships between community, public health, and healthcare systems. As you all know, we monitor progress and success through some key indicators highlighted along the lower half of this slide. All of these are in our national HIV strategy, and most of them are the key indicators for monitoring success of the Ending the HIV Epidemic initiative. So I'm going to provide national highlights for 4 of these today, namely HIV incidence, knowledge of status, linkage to care, and viral suppression. And then the other panel members will cover some of that and some of the others and some other things. We'll see, it'll be a surprise. But because I am here to highlight new national surveillance data, I did want to start with just a few items that are new to the data reports that CDC released a couple weeks ago. The first new item I want to highlight from this year's report is that in addition to presenting deaths due to any cause among persons with diagnosed HIV, the report now includes a section on HIV-related deaths, and tables include presentation of data for HIV-related and non-HIV-related deaths. Next, across all products, age groups were expanded to address the older population, and these age group expansions vary a little bit by report and demographic groups due to limitations with the data. But we do have 55 to 64 and 65 plus, which it used to be 55 plus. Finally, we've added visual cues to our products to indicate important highlights. So key points are highlighted with a magnifying glass, and important actionable findings are called to attention with an exclamation point. And then finally, the Atlas Plus is a resource where you can find the CDC surveillance data, and there, all national HIV surveillance indicators can be queried by those 10-year age groups for persons aged 13 and over through age 65 and older. And then for certain indicators, we have also provided options to view expanded age ranges for youth, so namely 13 to 19 and 20 to 24, instead of the chunked together 13 to 24. Or in addition, you can do both. And then also expanded age ranges for older persons, including 5-year age groups from 50 to 84, and then 85 and over. All right, so let's jump right in. I'm going to begin by talking a little bit about HIV incidence, which is the estimated number of new HIV infections per year. I'm glad to say that the data show that national prevention efforts are continuing to move in the right direction. The estimated number of new infections has continued to decrease, and in 2022, there were an estimated 31,800 new HIV infections. We typically look at 5-year trends, so the number in 2022 was a 12% decrease when compared to 2018. And much of this decrease was driven by a considerable decrease of 30% among young people aged 13 to 24. Through some of our CDC reports and increases in PrEP prescriptions, these suggest that the increased reach of testing and PrEP use and treatment among this younger group is contributing to this decrease. So data also show a significant decline geographically, with estimated new HIV infections decreasing 16% in the South in 2022 compared to 2018. New infections decreased 20% among white MSM, gay, bisexual, and other men who have sex with men, and 16% decline among Black MSM. For Hispanic and Latino MSM, the number of new HIV infections remained about the same, but due to these significant decreases among Black and white MSM, for the first time, Hispanic Latino MSM accounted for the highest percentage of estimated new HIV infections among gay, bisexual, and other MSM in 2022. I am pleased to say there were no increases in HIV incidence for any population in 2022 compared to 2018. I did mention on the previous slide that incidence decreased 30% in 2022 among persons aged 13 to 24 years. And you can see that downward trend on the slide on the very left side. That's the 13 to 24 year group. However, I do want to call attention to one group that we kind of rarely discuss. It's the 25 to 34-year-old group highlighted here. What is happening? Highlighted here. The largest number of new infections continues to be among persons in this age group, accounting for 40% of new infections in 2022. Now we'll move to our next indicator, the percentage of all persons with HIV who have been diagnosed, which we also call, we refer to as knowledge of HIV status. So at the end of 2022, an estimated 1.2 million persons were living with HIV in the United States, of which 87.2% knew their HIV status, which is a slight increase from 85.9% in 2018. Increased testing is needed among persons aged 35 to 44 years for whom knowledge of status actually decreased in 2022. And this decrease was first reported in last year's incidence report and continued in this year's report. Efforts should also prioritize populations with the smallest percentages of persons who know their status, which include persons aged 13 to 24 years, persons aged 25 to 34 years, American Indian and Alaska Native persons, and Native Hawaiians and other Pacific Islander persons. I think that maps provide a really great quick visual of how we're doing by jurisdiction. And so for the knowledge of status indicator, several states have actually reached or are nearly reaching the 95% goal, and those are in the darkest purple. The 13 jurisdictions listed on the slide and indicated in light purple on the map have the smallest percentages, ranging from 64.7% to 83.5%. All right, so moving on to linkage to care. Of the 36,470 persons with HIV diagnosed during 2022, approximately 82% were linked to care within 1 month of diagnosis. And this slide shows the groups with the highest and lowest levels of linkage to care within 1 month of HIV diagnosis. Groups with the highest linkage to care were Hispanic or Latino persons, persons residing in the northeastern region of the United States, and Asian persons. Groups with the lowest linkage to care percentages were Native Hawaiian or other Pacific Islander persons, persons with HIV attributed to injection drug use, both male and female, and this is based on sex assigned at birth, American Indian and Alaska Native persons, and Black and African American persons. Again, I just wanted to show these percentages by state. So here we can see linkage to HIV medical care within 1 month of diagnosis, and the darkest 13 states, it's going to be 13 on all the maps. So the darkest 13 states had less than or equal to 80.1% of persons linked to HIV medical care within 1 month. 9 of those 13, or 69%, with the lowest percentages, were in the South. 6 states exceeded 90% in 2022, including 1, Vermont, which had 100% linkage to care. So good job, Vermont. All right, and then here we see some highlights for viral suppression. In 2022, 65.1% of persons living with diagnosed HIV were virally suppressed at their most recent test. Groups with the highest viral suppression were persons aged 55 to 64 years, white persons, and persons reporting multiple races. And then groups with the lowest percentage of persons with viral suppression were for persons with HIV attributed to injection drug use, both male and female, Black persons, and persons aged 25 to 34. I want to pause here and just note that the persons aged 25 to 34 has shown up as decreasing knowledge of status, very high incidence, and one of the lowest groups of people with viral suppression. And here's our map. So this is for viral suppression in 2022 by area of residence, and in the darkest 13 jurisdictions, those are the lowest percentages. Those are less than or equal to 63% of persons with viral suppression. Of those 13 jurisdictions, 8 of the 13, or 62%, were in the South. And no states have reached or are nearing the 95% goal. The highest viral suppression was 81.2%. Right, so as we've observed overall from the report highlights, gaps in prevention and care persist for certain populations and areas of the country. And we just had some wonderful site visits that we've talked about a couple times today already, and several demonstrated very clearly that if we're going to close these gaps and meet our national goals, a whole person approach is very needed to identify and overcome social and structural barriers across the HIV prevention, care, and treatment continuum. I'm going to end with that and turn it over to Tori. And yes, thank you.
Thank you so much for that presentation. Certainly a lot to unpack there, and I'm looking forward to the Q&A a little later. So next up, we're going to have Katarina Kim, who is a public health analyst with OIDP, OASH, and also HHS.
Hi, everyone. My name is Katarina Kim, or Kat Kim, and I'm within the Office of the Infectious Disease and HIV/AIDS Policy. And I will be talking about America's HIV Epidemic Analysis Dashboard, specifically what can AHEAD do for the PACHA community? And 3 questions I'm also going to be answering today is, what is AHEAD? I know that's kind of new to some people. What are the EHE indicators on AHEAD, and how to use AHEAD? So before I get into what is ahead, let's see how does ahead fit into the big picture. So during the last administration, EHE was announced ending the HIV epidemic. And so with that, it came, how can we monitor our progress to EHE? So ahead was created as a visual way of representing this data. And this data is actually, we receive it from CDC, Stacy and her team. And so we do get to work closely and we present some of the data that is available on CDC's Atlas Plus. And so what is ahead? America's HIV epidemic analysis dashboard. It is one tool used to measure progress towards ending the HIV epidemic. We know that there are many different HIV dashboards available. Jurisdictions can use their own a local dashboard. There's CDC's Atlas Plus, there's AIDS View, there's HRSA's Compass. There are many things available, but specifically for ahead, it was created for our 57 priority EHE jurisdictions. So we do now have expanded to hold data on all 50 states, but we do prioritize our priority jurisdictions. So what are the EHE indicators on ahead? So we have 6 EHE indicators. They're incidence, knowledge of status, diagnoses, linkage to HIV medical care, viral suppression, and PrEP coverage. So on ahead, you can see them either expressed as a count, which is incidence and diagnoses, or you can see them expressed as a percentage, which is knowledge of status, linkage to HIV medical care, viral suppression, and PrEP coverage. This data specifically comes from CDC's HIV surveillance report, and they are updated on an annual or quarterly basis. So I know that can sound kind of confusing. So our data is annually updated with CDC's new release of their HIV surveillance report. And then for 2 of our indicators, we do update them quarterly, and they are preliminary data. So that is for diagnoses and linkage to HIV medical care. So this is some of the stratifications that we have available on ahead. I know it looks a little lengthy, so I'm not going to read it out, but specifically, that what we have highlighted is, as Stacy has mentioned beforehand, is that we are updating our age range from just 55 plus to 55 to 64 and 65 plus. And then also you can see we have some asterisks next to gender. It is specifically only available in our national view for diagnoses, linkage to HIV medical care, and viral suppression. So what is the purpose of AHEAD? AHEAD was specifically created to help visualize and interpret HIV data in an accessible and engaging way. I know when I tell my family that I work in data, they're not always interested in what I have to say, but we try to make it a bit more interesting this way. So data, when seen in giant tables and small charts, it can be very overwhelming. So AHEAD was created for individuals that are maybe not as data savvy. One of my things that I tell my team is that I want my parents to understand what I do and can see it and enjoy it as well. So in the So in this video demonstration, it shows what a new user would see when visiting AHEAD for the first time. It gives you a walkthrough of our 6 EHE indicators, shows you where our stratifications are by location and demographic, and then it'll also show you how to populate data on our site. And so specifically here, you're looking at the national view of incidents. It'll just give you a few walkthroughs of things to check out as well. And then something that we've also done as we work on our user experience and listening to user feedback is that we've created a light and dark mode. Everyone has a preference, and so we just want to be able to cater to that. And then something that we've also done for our estimated indicators of incidence and knowledge of status is that we have a toggle on feature of our confidence intervals, so you can visually see what that would look like on our charts. So how can you use AHEAD? So when speaking with our users on how we can better enhance our experience in the visuals on AHEAD, we talked about what does that look like in an overview. So they've also shared that they use our visuals specifically in presentations, printouts, grant applications, anytime when a visual would be necessary. So specifically doing this, I was introduced to AHEAD as a student learning about dashboards and HIV data, and I found AHEAD very engaging in this way as I was also checking out other platforms. So we knew that people learn best through doing, so I also have another video on how you can look at data stratification. So each of our demographic stratifications be able to be clicked on through the location. You can either type this in, you can also scroll down and find your specific jurisdiction. And then for our demographic filters, there is a select all, or you can personally type in and click on which ones you would like to see. And then something that we have added from our user feedback is that we have a share out. So you can share out with your selected features. And so if someone were to click on that link, they would see the exact graph that you have pulled up. And then also you're able to download a PNG file, which is a nice file to be able to put into a presentation, to be able to download, or just to send to anyone you want to. So the other thing that we have updated with our user feedback is a mobile version. So I'm just going to play it right here on with this demonstration. So we live in an age of where technology is available at our fingertips. And so you are able to put on a head on your phone and be able to find data if you're in the middle of a conversation, you think, I want to know what, let me see, Texas's data looks like. You can go onto head, go to Texas and also put in any stratifications you'd like, and you can see a visualization on your phone. If you're in a conversation with some colleagues, you'll be able to be like, here's this graph that I've pulled up. So it's just one of the ways that you can see it. And then in this specific demonstration, it is actually clicked on our preliminary quarterly data. So our preliminary quarterly data, specifically for diagnoses and linkage to HIV medical care, are not readily available without toggling on this feature. We just want people to be aware of what data they are looking at and what preliminary data means. So the last feature I'll be sharing with y'all today is our social determinants of health data. So we have 7 social determinants of health indicators available on AHEAD. 2 of them are national only, and they are data provided to us by CDC's medical monitoring project. And these are housing instability / homelessness in people with HIV, and then HIV stigma among people with HIV. The other 5 SDOH indicators that are available are poverty, uninsured, income inequality, educational attainment, and employment. And this information is pulled from the census. So in this demonstration, you can see if you go to our jurisdictional dashboard and toggle over to social determinants of health, you can see the GIS map pull up our EHE jurisdictions across the board. And one of the ways that you can click on a jurisdiction is you can actually use the map to click on it or type it in or scroll to it. So specifically in this demonstration, you can see that it shows you the comparison specifically of Alabama versus the national of the SDOH indicators. And so we are also always looking to improve our SDOH information. So if there's any feedback that anyone, our PACHA members or the community would like to give, please let us know. Okay, so who is the AHEAD audience? So AHEAD was created for our EHE communities, but it's really now anyone that's interested in data, anyone that wants to learn more. We're always trying to improve our site better for our users because we do want to introduce HIV data to people and get people questioning, what can I do? What are some questions that I can ask? So if you'd like to check out AHEAD, feel free to scan the QR code, or please feel free to reach out and to learn more.
Thank you so much, Katarina. You know, as a physician from an EHE jurisdiction, I know that I will be using the AHEAD dashboard now. I was not familiar with it, so I'm so thankful to you for sharing that dashboard with us today. I now have the great honor of introducing our illustrious co-chair of PACHA, Dr. Vincent Guillermo Ramos. He is, I have to pull up all of his titles. They're not here beyond PACHA co-chair. He has many titles, and we thank him for hosting us all last night at the most glamorous dinner I have been to in many, many years. And he is going to present on the gaps and inequities in data around treatment, testing data, and a statement on the respond pillar. So thank you so much, Vincent.
Thank you very much, Dr. Tukes. So a couple of things. When we were organizing our presentations, the specific request that came to me was to focus on some of the places where we might not be making as much progress. And so forgive me in advance that I'm going to take a somewhat different approach. It doesn't make what preceded me untrue, but I think there's some more nuance to the data. And that's true of any data. The other thing I want to say is that this morning, as I was listening to the conversation and the presentations, I kept on hearing some recurring themes. I heard a lot about implementation and this sort of tension between plans and what we say versus what the actual experience is on the ground. I also heard yesterday and today questions about inequities and really looking at racial and ethnic groups and highlighting, well, what do those data say about specific groups, not just overall? And I heard today questions about specific communities, including the MSM community. So all that fits into my presentation. I'm going to be talking about the Latino community in the US. It's the community that I have worked closest with, both as a nurse scientist and also as a nurse practitioner who actually provides clinical care to that community. But this could be about other populations as well. I just don't have time to do all of that, but I would ask us as a committee to thinking about the data in ways that sort of highlight other communities as well. So a couple things stand out to me when I look at the most recent data and actually data over time. It's important to recognize, and I want to be super clear about this, that we have made much progress. It would be unfair and it would be completely irresponsible of me to say that we haven't done terrific work as a nation in really eliminating HIV. But that progress has been uneven. And I think I heard lots of sentiment just a little while ago about things needing to speed up. I think there are three basic relationships that I see. The first is that some communities, while they're experiencing decreases, those decreases are inadequate. They still remain too high. Another is that there are some groups that are stagnating. I think we just heard an example of that from Stacy from 2018 to 2022, Latino community, roughly the same number of new infections among Latino MSM. But some communities, I would argue that we have been seeing increases, and we very rarely talk about that. And so I want to spend some time talking about that. Latinos are a population, in my view, where HIV infections, the estimated infections have been increasing. And I'm going to highlight specific subgroups where I think we should be focused. So I want to start by saying that in 2020, a very large effort, there are a number of people in the room, Duvia, and I think Natalie's here as well. Yes, Natalie is here. But really under the leadership of Guillermo Chacon and the Latino Commission on AIDS and something called the Hispanic Health Network, about 100 national organizations got together before this paper came out, and we started asking questions about how we could better respond to the Latino epidemic in our country. And one of the products that resulted from that was a paper that we published in the American Journal of Public Health that really tried to raise visibility about what we called an invisible crisis. And one of our main tenets was that we felt that there was inadequate attention to the Latino community and that we weren't really getting enough response. I want to point out that if you read this paper, you'll see that we sort of forebode that if we didn't make a change at that time, that we would actually wind up with a worsening epidemic among Latinos. And so I want us to kind of put a pin in that point because I think it's an important one. This is my read of the data, including the most recent data that was released by CDC. I believe it was on May 21st. I may be mistaken, but I was very recently. And so I'm actually looking from 2010, and I'm doing that intentionally because I want to show a trend over time. And what you see here is the percent change. And so again, it doesn't mean, for example, that the African-American community doesn't have higher estimated HIV incidence in terms of the actual count, but you can see across every group, most markedly overall, you can see there's been a 19% decrease in terms of estimated annual new infections if you look at the period from 2010 to now. If you look at white, if you look at African-American, Black, reductions, Latinos have experienced a 12% increase. And I think this is important because if you think about the point that I made just a minute ago, that we were arguing this when we met and we were convening nationally with 100 Latino HIV prevention and treatment organizations, that we were concerned about that. That trend is not new. It's been something that's been going on for some time. So just to kind of illustrate this a little bit, you can see here the percent change from 2010 to 2022. US overall, a drop roughly 19% or 1 in 5. You can see here Latino overall 12% change in estimated new infections. I think what is probably more, in my view, problematic is when we start to impose some of the subgroups within the Latino community. You can see here 24% increase among Latino MSM And if I take it one step further, you can see, and this is a group that I think we should be particularly concerned about, 25 to 34, see a 95% increase among Latino MSM. If I pause for a second, I'm not going to talk about other groups, but I'm going to flag this. I think I'll use, is it a yellow mark, Stacey, that you guys used to say important, urgent point? Okay, so I would put a yellow mark on this group, young MSM ages 25 to 34, particularly young MSM of color, and I would extend that to African American, but I would also say that we should be looking at European American as well. And so I think this is a very important population, and I have huge concerns about this. I think what was really troublesome is that for the first time in the most recent data that was released by CDC, we see Latino MSM accounted for more estimated new HIV infections than MSM of any other race or ethnicity. You can see the numbers here. These are the counts. And this was not true prior to 2022. And so this is actually a new trend that is building what I just said about 2010 to now and the increases. So what do we do in terms of understanding this? I would argue what we've heard, this morning and what we've talked about for a long time, that we've got the tools, we've got the strategies, we have the plan. All that stuff is written beautifully. We've got all of the science that we need in order to end the epidemic. What we've got to figure out as a nation is how are we going to ensure that our approach to prevention treatment is more equitable and that we are reaching those communities that stand to benefit the most and that have historically been less focused on. Here are some numbers that you can take a look at in terms of testing, prevention, treatment, specifically for Latinos. And I offer them not because I'm trying to say we're doing a bad job, but what I'm trying to say is that we need to focus more on these communities. You can see here that 16% of Latinos are unaware of their HIV status as of 2022. You can see here in terms of PrEP that 76% of Latinos with PrEP indications were not prescribed PrEP in 2022. You can see in terms of retention, 54% of Latinos living with HIV were not retained in HIV care in 2022. And you can see in terms of viral suppression that 46% of Latinos living with HIV were not virally suppressed at some point in 2022. So again, I hope that the story and the narrative is building that while everything that we've said around the aggregate is true, we still have work and we need to elevate some of these populations that I think are receiving less attention. So what do? My good colleague and friend, Dr. Sullivan, who's presenting next, he reminds me that it's important to not just focus on the inequity, but to propose solutions and to think about ways that we can move forward. So I want to highlight some things that I heard, not just back in 2020 when we met all the Latino national organizations, but we just met on May 5th and 6th in DC. We spent 2 days together. And some of the things that I heard in our discussions was the importance of really increasing the visibility of the Latino HIV epidemic. We are the largest racial and ethnic minority group or minoritized group in the United States, and yet very often is there a focus on us. I think most of the time I would argue that when you do hear about Latinos, it historically has been about the border and migration. We have many other needs and issues. We need to start to make that much more visible. We need to harness broad societal and organizational political will to eliminate HIV inequities. Inequities is the word that I use. I've said this before. I don't use the word disparities because I believe that they're unjust and unfair. And I think it's important that we really look at how are we going to eliminate those inequities? And that means addressing the social determinants of health, which are the root drivers of the inequities, but also the deliberate and conscious, and perhaps some would argue unconscious, I would say deliberate and conscious, ways in which we distribute our resources, how we think about our tools, and the lack of alignment between the actual tools that we have, including things like funding, treatment, PrEP, et cetera, and the communities that would benefit the most from those. And I would argue the Latino community is one of them. We need to bolster our leadership. We're thrilled with Director Ruiz. We need broad leadership across the country from the Latino community and really meaningful community engagement. I think MPOX is a great example of how the CDC did some really innovative things to actually turn the tide around community engagement. We need more of that in terms of HIV in the Latino community. We have to foster accountability and specific actions and actors. I think we've had a lot of convenings. We've had a lot of conversations. We need specific actions and actors, and we need to ensure accountability. Latino workforce. We need to build an effective workforce. Unfortunately, we have right now in our country a Supreme Court decision that says that the role of race cannot be considered in admissions processes. I'm going to argue that that's completely against the science. We had a comment earlier today from Director Ruiz that priority number one was the alignment of the policies with science. The science says that when you have symmetry between provider and patient, that you get better outcomes, better screening, better treatment, more satisfaction. And yet our hands are tied in many ways by this decision, and we run the risk of not having the right workforce to address the complexity and the diversity of our nation. We need evidence-based laws and policies. I think that's been already emphasized. We need to coordinate our efforts across key stakeholders. I'm really happy to hear that we're not simply going to stay within the HIV prevention and treatment organizations. While super important, we've got to reach out to other groups. And I would argue, for example, one group that I'm very involved with is Unidos US, the largest Latino civil rights organization in the nation. How much HIV work is Unidos US doing? How much are we engaging them? How are we pulling them in their infrastructure and network to help leverage a Latino community? And then I would say we need to eliminate the structural and cultural and linguistic barriers, including the anti-immigrant sentiment, discrimination, stigma, and the mistrust that we have as a community in our HIV prevention and treatment services. I think we can do this. I think that it's possible. Last year we published a paper that was focused on, are we on track for ending the HIV epidemic? And I think there was some concern in the data that we saw in terms of our need to speed up. But what I can certainly assert today, and I'll end on this, is that without an increased focus on the Latino community, we cannot end the HIV epidemic. Thank you very much.
So thank you for that. And our last panelist, our presenter today is going to be Dr. Patrick Sullivan. He's a PACHA member, global co-chair and principal scientist at AIDSview. He's also Charles Howard Candler Professor of Epidemiology at the Rollins School of Public Health at Emory University. Patrick will then close us out with some gaps and inequities on data around prevention and also about HCV.
Oh, very good. Thank you so much. So I'm going to close out just with some maybe high-level thoughts about what the data say about equity and determinants of population impact. So, if you've gone to any HIV prevention conferences, you've seen these particular suitcases, which always introduce like what tools we bring to this effort. But what I really want to suggest today is that what will determine if and when we manage the epidemic or end the epidemic, fix it, has to do with several things. So we have the suitcases, but I want to talk about sufficient coverage of treatment and prevention that needs to be deployed in the highest priority areas and delivered equitably. I'll talk a little bit more about this, but I think that means that those at greatest risk get the most access. I loved in Dr. Warren's presentation earlier that he was presenting the vaccine to case ratios for mpox. We want the communities that are experiencing the most cases to have vaccination in proportion. It's that idea. And then it needs to be sustained over time. So how are we doing with deployed in the highest need areas? These are maps that depict new HIV diagnoses by states in 2021, and this expression of PrEP use, PrEP to need ratio, which I'll talk more about on the bottom. And so what we see is that the southern states, as has been highlighted already, and I think all the presentations, have the sort of highest rates of new HIV diagnoses. And so the question is PrEP being used in those states proportionate or in consideration of that high risk? And on the bottom, you see that the southern states are exactly the ones that are in the lowest quintile of PrEP use. So for reasons that we'll talk about, there's a mismatch between what that need is in terms of new HIV diagnoses and the interventions that are needed to prevent them. Do we have sufficient coverage of interventions? And the levels of coverage matter for viral suppression for sure, which is about improving health and has the collateral benefit of reducing onward transmission, but also for PrEP. So these data are first just meant to show that over this decade, that there's a lot of variation in how well states do with coverage, for example, of PrEP. And although these numbers will look low for coverage, remember that they're the whole decade from 2012 to 2021. The real point that I want to make is if you look from the 10 states that sort of did the best with coverage at about 16% averaged over the whole period, to those that had the lowest coverage, there's a threefold gap in how well states are doing. I'll say a little bit more about why that might be. But maybe more important is the consequences of that. So this looks at the relationship between being in one of those groups of PrEP use, the PrEP coverage, and accounting for viral suppression. And I think it's important when we talk about antiretrovirals as a tool in the epidemic. They are used obviously both for prevention, but also that treatment is prevention, as has been said. And so this analysis takes into account levels of viral suppression, which also help to reduce onward transmission. So in the group of 10 states that had the highest levels of PrEP coverage, those groups experienced on average about an 8% decrease year over year in new diagnoses. Conversely, the states in the lowest quintile experience non-significant, but it looks like a couple % increase per year. So the level of coverage really matters. And this p-value just says that there's statistical evidence that to support a statement like the better that you do with equitable PrEP use, the higher, the more reduction in HIV new diagnoses you're going to see. And then deployed equitably. That means in the communities that experience the most risk. And this introduces the idea that instead of looking maybe even at coverage, we might think about these ratio-based measures as was done for MPOX, where we say we'd like to think about the number of people who are on PrEP in a group, but the need indicator should be how many new infections are occurring in that group. And so this creates this ratio-based measure. And one of the problems is we don't really have a clear target for like what should that number be to change things. But I do want to suggest that Sam Janess has used models and estimated that might be 25 to 42 people per new diagnoses in a group. So that might mean per new diagnosis in the South or in Tennessee or in Hispanic Latino people. And how are we doing in the US with that target of adequate coverage? If we take a 28, which is another sort of talked about number needed to treat, we're actually at about 12. So even by that metric, we have a lot more work to do to reach the people who would need it. And again, the idea that equity indicators don't say that we're going to compare or give every group the same leg up in prevention, but that we're going to try and give a bigger assist to communities that experience more impact. This is a QR code for a paper, but I wanted to just highlight this one figure from it, which is if you look at that sort of equitable question about PrEP use, that on the right is the main conclusion of this paper, which we compare Black and white equity in a ratio. We see that the equitable use of PrEP in Black Americans is only at about a fifth or a sixth of what it is in white Americans. That equity-based measure is more like a 77% decrement for Hispanic Latino communities and is at about 38% for women compared to men. So these are pretty profound gaps in equity. And the reason that this is important is what happens if we tolerate inequitable PrEP use. This is modeling that was done by William Godel, where he just sort of asks among men who have sex with men in this matrix of equitable PrEP use, which would be that Black and white MSM, for example, have the same PrEP to need ratio in all those scenarios. The one that I've highlighted is one that reflects what we think is happening in the United States, which is that there are 7 white people on PrEP, white MSM on PrEP for every 1 Black MSM on PrEP in that PrEP to need ratio configuration. And in that scenario, we think that the disparities in new HIV infections are going to increase. So PrEP can actually decrease infections overall, but widen those disparities. And that's why I think we need to be asking ourselves at every level, national, regional, state, local, using PrEP equity indicators rather than coverage indicators. And so what can make these equity indicators better? Unfortunately, there are things that are needles that are hard to move. But this modeling by Aaron Siegler showed that if you have both PrEP-DAP and Medicaid expansion in a state, that state is significantly more likely to have better equity. Either PrEP-DAP or Medicaid expansion moves that needle somewhat. And so the message here is, I think, that either policy will move us maybe towards PrEP equality, but when you combine those, they actually move towards equity. And I want to say a word about white-black PrEP inequities, and I really appreciate the context you provided around about Latino inequities. But I want to say that all of these, we should just, before we start looking at them, should say that they're because of systemic and structural racism. And until we address that, we won't address these intermediate problems. But I want to acknowledge that these aren't the fault of communities. They're problems with access to healthcare, proximity of PrEP providers, PrEP stigma, HIV stigma, criminalization, which is differentially used against Black people, and living in areas with regressive policies and mistrust of healthcare, which is well placed based on our history. So I'll just quickly say that for geography, these are data that were just recently done by one of our fabulous earlier career colleagues at Emory Noah Mancuso. And this shows the drive time to the nearest PrEP clinic for every county in the US. Literature suggests that people for routine healthcare maintenance kinds of things will go up to about a half hour. We'll go farther for treatment than we will for prevention. And so in this slide, every county that is yellow, orange, red, or the dark brown color are places where people are so far from a PrEP provider that they would be unlikely to travel for that routine care. There are some solutions to this have already been discussed, and that might include teleprep, that might include PrEP by mail, that might include mobile vans, and there are programs that are actually bringing PrEP into communities in the rural South in these ways. So I just want to wrap up by saying that these aren't sentiments, that the data tell us these things, that to get the most out of HIV treatment and prevention, we need to be sure that the people at greatest need are getting the lion's share of the benefit. I tried to show you with the equity indicators that that's not happening, so we need to change that. Access to prevention and treatment tools must be equitable. We need to not use proportion of Black, white, and Hispanic people who are receiving a service. We need to norm that to the need in communities. We need to ask who is left behind and what are the barriers to access for those who are left behind. And I would suggest that payment, as we saw with the PrEP-DAP and the Medicaid expansion, and distance are important factors there. And then policies and programs, Medicaid expansion, PrEP-DAP programs, although we haven't tested this in models, national PrEP program, these are things that just logically and by data offer the opportunity to reduce the barriers to care and improve equity. And how well do we need to do to end the epidemic or to manage the epidemic or to wrestle it to the ground? More is better for treatment, more is better for PrEP, more is better for testing. But because we have limited resources, we need to always be asking, what are the equitable investments, the investments that are going to differentially increase access for those who are at highest risk of the poor outcomes? Those are the equitable things to do. Those are the just things to do. And those are also the best investments according to the data that we have. I want to end just by saying a lot of the data that I presented are available in these infographic formats on AIDSview, which you can download and use. I really like the complementarity of what the HEAD dashboard does for EHE jurisdictions, and we share your enthusiasm that some people don't want to see these slides with ratios and ratios of ratios. So if we can use these to sort of illustrate some of these gaps, for example, this one about PrEP use in the South, I hope that these are useful to you to use in your own work. And I'll acknowledge funding by NIH and the AIDSview resources are supported by Gilead Sciences. Thank you.
I just have to say, I mean, what amazing panelists. The way that Patrick and Vincent in particular, we all saw the 100-page surveillance report, but the way that you really you really rang the alarms for what we should really all be concerned about was just phenomenal. And I thank you so much for those presentations. And Director Ruiz, you have a lot of work cut out for you, but we're all here to support you in the task. I wanted to start, being from Miami, I was very, very concerned to see the data that you presented Vincent, on the 95% increase in infections among young Latino MSM. I am really, really concerned. And also being from Florida, I wanted to know, what impact do you think the anti-LGBT, the anti-immigration laws are having on these this astoundingly high increase in infections?
Thank you, Dr. Tooks. So a couple of things. One thing that I would say that probably is a pretty straightforward answer is that when I look at the geographic spaces or the jurisdictions where there have been increases in estimated incidents, unfortunately, Miami is one of those places. And so I think that that is available in the data. And there are other sort of Latino geographies like LA that also are contexts where estimated incidence is going up. So we should be concerned. I think in terms of issues regarding policies, I think there's lots of data that historically has shown that where there's criminalization, where there are more difficult sort of circumstances for the people who would benefit the most from whatever it is that we're trying to do for our purposes, prevent HIV or help people living with HIV to remain healthy, then it becomes harder. We see greater concern, fear, lack of engagement in services. Probably, I don't remember when it was, but it was fairly recently, maybe about a year ago, in one of the MMWRs. There was a pretty, in my mind, shocking and alarming report about sort of stigma among in the Latino community of individuals who were living with HIV and what they were reporting about their experiences in our care continuum. And it was pretty bad, Dr. Tooks. They basically were reporting that they felt high levels of stigma, and it was coming from the health system, from the providers, from all of us, the systems, the context, and that it was interfering, with their engagement and ability to benefit from care.
Awesome. And since you shouted out the guys, I certainly want to shout out the women as well. Thank you both. It's incredibly difficult to talk about national data in anywhere, but particularly in a room of folks who work across the country. But so much of our work is focused in the South. So thank you for that. And thank you so much, Kat, for giving us yet another tool to add to our toolboxes. I have an interesting question. Well, it's kind of a statement and a question, and I think this would be great for anyone to respond to, but also something that could be really important. Those of us who are public health advocates, public health professionals, scientists, folks with good insurance, I think many of us view data, and we really approach our work from a very privileged and middle class mindset, whether we acknowledge it or not. I think some of us, I can't speak for everybody in the room, but I would imagine that the Black people at the table who work with Black people, especially in Black communities, would also be a bit surprised if that 29% decrease in Black people and new infection rates for Black people, if that's even close to being factual. Certainly, I want to make it clear, I'm not challenging any of your work because we love data. With that being said, how were the numbers that we've all talked about today, and how is data being calibrated so that it more accurately represents what we just experienced with COVID? How is it more accurately calibrated so that it represents disparities, particularly, Marvell is from Memphis, particularly in the deep South, where we all know that the numbers for Latino, Black people, multiracial people is far worse than it is in places above the Mason-Dixon line. Do not be afraid.
Yeah. So Tori, I think you're hitting on some important points. And so I guess my only response would be to say the following. I think the data are in fact accurate. I think that just because they're in the case of my presentation, I really reflected the percent change. It doesn't mean that the African-American Black community still doesn't have the highest estimated incidence of any group. It just means that the change was whatever the number was I presented, the 29%. And so, but that's overall. And I think the same basic argument of how we have to interrogate the data by subgroup, by different communities. So for example, in preparation for today, I was looking at data for transgender Latinas. And what was really clear is I couldn't find, maybe Stacey, you could help with this, I couldn't find incidence data. What I found was diagnoses, and those diagnoses were pretty shocking to me. And that was true not only of Latinas, but of African Americans. And I would argue white transgender females, it was the worst, if I have that right, Stacey. But I think the point that I think we're trying to get across is that as we're telling our stories about data, we need to celebrate our successes, but we also need to sort of dive deep. And I think what Dr. Sullivan was saying about these indicators of equity, boy, is that so important, because it will help us to have nuance in how we're thinking about our approach.
I mean, if we want to get real down and deep in the geek, I think we have confidence in the surveillance data, and I've had the privilege of seeing surveillance systems in other countries and how other countries do it and how we do it in the United States. And I do think the U.S. made an early and substantial and world-leading investment in surveillance. However, surveillance is not a system that goes out to characterize all the communities that are at highest risk. It filters through, I may be speaking in someone else's lane, so I'm happy to be put in my lane, but it really utilizes data that come from other healthcare structures. And because of some of the things that I mentioned about access to healthcare, about trust in healthcare, about distance to testing, about all these things, the access to healthcare isn't equitable. And I think because of criminalization in the South, which I really appreciate you raising this, and I think we just need to put it in each conversation, is that it may be that willingness to test in the kind of setting that feeds into surveillance systems, I think would be understandably less when we see cases. There's one going on in Georgia now that is a knowing exposure case. So criminals, I'm saying a couple things. One is, I'll go back to my statement that systemic and structural racism also challenge the ability that the surveillance system is, we're going to compare Black, white, Hispanic, young, Black, Southern, and Northern, make an assumption that there's equitable access on the data flows into that system. And so I think for people of trans people, that may be about how data are collected. I think that for a lot of communities, fear of mistreatment in healthcare settings, fear of criminalization may actually change the patterns of how and where people test. I want to make a small plug for a program that CDC is supporting called Together Take Me Home, which is a direct-to-consumer provision of HIV self-test kits that are mailed out. And it bypasses the stigma that some members in our communities can experience even when going for testing, which are the places we would hope to be supportive. So the thought is you can order these online, you can order these through the website, you can order these through Grindr. There's a persistent button in Grindr to order a test kit. And that for some people, taking that first test may be a gateway to sort of knowing what to expect. But that test, for example, might not get registered. And so I just want to say, like, again, with all love for surveillance data, I think we have to recognize that we have a lot of the challenges that increase the vulnerability of members of our communities to HIV also have to do with how people seek care and when that contact with healthcare occurs. And that may also is just something we need to figure in. So I don't know if that answers your question or not, but I think it's an insightful question. And I think even surveillance people would say, when we see something that doesn't make sense or doesn't jive with what we're seeing, let's just ask about that. Like maybe our perception is not the perception of what's going on in the country, but I know our surveillance colleagues would say, tell me about that so that we can ask about, like, are there some biases in how we're understanding this data?
Thank you. I understand that was could have been a really tricky question / comment for you all to respond to. So thank you. Did you want to add anything, Pat?
I'll just add right piggybacking on what Patrick just said, is that, the surveillance data can only tell us so much. There is so much context behind everything that is in the numbers, and so, like, without digging deeper in that way, we can't get to your answer.
All right. Thank you for plugging Together Take Me Home. It is a phenomenal program offered by the CDC. We are going to take questions from PACHA members, and we only have 10 minutes. So I guess I will start. Oh my gosh. Oh my gosh. Oh my gosh. No, don't try that, Carol. No, no, no. We'll start with Jesse Mylan on this end, fresh from the U.S. Capitol.
Thank you. Thank you so much. And all four of you did a magnificent job in presenting this wonderful updated data and in different perspectives. Jen Cates and I serve on the PEPFAR Advisory Council, Advisory Board. And so if we put this new data in the context of the world, we are way behind. We have sister nations that are achieving 95, 95, 95, and we are only at 65% virally suppressed. We still have 35% not appropriately linked to care and 13% who don't even know their status. Now, the additional backdrop that I've just shared with 15 members of the United States Senate this morning is that we are dealing with flat funding for Ryan White, flat funding for CDC, basically still flat funding for HOPWA. So what do we as PACHA need to do to get us to get that additional 35% to know their status? What can we do to make sure, to be linked to care and to know their status? Thank you, Patrick, for suggesting that Medicaid expansion is one important step and that a national PrEP plan, which we know has been proposed by this administration, would be very helpful. But are we at PACHA doing what we need to do to say to the secretary, there may need to be some additional moving of deck chairs around the existing ship if the ship is not going to get larger anytime soon. And so we cannot continue to let 35% of our population, of our people, not be virally suppressed, because they're the ones who are at risk of an AIDS diagnosis. And the 13% who do not know their status are the ones who we have known for more than a decade are the ones fueling new transmissions. So if the ship is not going to get larger, what is our advice to the secretary to put additional chairs on the ship or to move other resources to where it needs to go? Because we're going to hear this afternoon from our federal partners that they are maxed out. 95% of the people in Ryan White are already virally suppressed, but that's not the 35% who are not yet virally suppressed. So I'm urging our committees as we meet this week to think of what resolutions and solutions we can create by August, when that body meets again, for recommendations to the secretary about what we as PACHA recommend that he do to help us move this needle. It cannot be simply that the national HIV strategy is in place if it doesn't have the resources it needs to make a major change. And I think if that's not our role at PACHA, I'm not sure what we're doing, because we've known versions of this data for decades. And if it's not going to improve fast enough, we will not get to 2030 with the national goal of ending this epidemic.
Thank you as always for your eloquence. I'm sure that question is largely rhetorical, but we really, really thank you for bringing that to the table. We don't have much time, so I want to move on to some people who have not had a chance to speak yet at this meeting. So I want to start first with Natalie.
Good morning. So I think, Patrick, you ended with the call to action. It kind of goes in line with what Jesse is saying, is we need equitable investments. And so from the presentation, what I'm getting, right, is a need to focus on the Latinx community. And the call to action is from the PACHA members, as well as our federal partners, is we need allyship. We need allyship to make Latino community a priority population. And I'm not saying to replace, I'm saying in parallel to what we have done for other communities. And so for us, is as important it is to address these other communities, so it is to focus on the Latino community. And I think for me, I think that's the frustrating part, is when I see the data and someone who has dedicated my career to working in HIV and someone who's a macro level person, and to see that there is no progress. And I said this in the cis women panel that we had at our last meeting, is stability is not progress. If the Latinx or cis women are not accessing or not provided with prevention services, are not uptaking PrEP, we're not going to have progress. And so I think, again, my comments are more the call to action. We need your allyship. We need to increase the visibility of what's happening in the Latinx community. And we need culturally and linguistically responsive systems, because if Latinos are going to healthcare systems that are not offering healthcare in their language, translation, and lack of access to Spanish-speaking providers, and I'm not just talking about medical providers, mental health providers, case management, other support systems, if it's not provided in their language, that's going to continue to be a barrier, and people are not going to return and are not going to achieve viral suppression or achieve retention and care. Thank you.
Thank you so much, Natalie. And again, that was much more of a rhetorical response. So thank you again, because you all are giving some incredibly important points and allowing us to move forward in the conversation. So thank you all again for that. So who do we have next? I believe Duvia. And let's go over who the order after that. Duvia, followed by
Mackenzie,
and then Carol,
and then Ty.
and then Ty.
Thank you so much for the wonderful data that you've presented today and for sounding the alarm on the Latino community. We cannot stress enough how important the data is and how important it is to bring these resources to the community in an equitable way. We are still seeing in the southern parts of the nation, Latinos with a really high incidence of HIV infection as per the data that was presented. And I would venture to say, aligned with what Tori was mentioning, that not every Latino is represented in the data. There's a lot of communities that are living still invisible, still in the shadows due to the fear of criminalization, right? And anti-immigration laws. That is a reality that is happening. Another reality that we know is that individuals that are living with HIV, that are on treatment, is the #1 way to prevent HIV transmission. The second largest way to prevent HIV transmission is individuals that have access to PrEP. We have the attention of the Latino community. We have the interest of the Latino community. What we don't have currently is the funding to support individuals that are uninsured or underinsured. We do not have access to pay for medical bills for PrEP patients. We do not have access to pay for labs for patients. So as a nation, I want to sound the alarm on something that might seem so small, but yet it's such a large impact for that community. It would make such a huge impact if we were able to move the national PrEP strategy to provide coverage for everybody, to provide accessibility to these communities, because that is the key. If we provide the access and we provide safe spaces for this community, the community will come and they will trust us and they will answer. And that is how we are going to be moving the needle. So thank you so much for your presentations and for the data and for sounding the alarm. Patrick, Vincent, Stacy, and Kat, I really appreciate it. And, you know, I hope that as Mr. Sullivan mentioned, that we, you know, by August have, you know, some sound recommendations for the Secretary of Health and Human Services.
Thank you so much, Duvia, for your important comment. I have received a letter from the chair that we must end in 120 seconds. So 60 of those go to Mackenzie and 60 of them go to Carol to bring us home.
Wonderful. Thank you. Thank you, panelists. Thank you so much, moderators. Really appreciate everything you're doing. My question has to do with data. With respect to if the goal is to end the HIV epidemic, I'm curious to the panelists if there are any data points that you'd like to see CDC, HRSA, or other government agencies collect.
Well, now the microphone's on. I mean, how to answer this? I think that in terms of the ending the epidemic goals, we probably have a sober view that we're not on that on that trajectory. I think as these kinds of goals are set, they're often set with this sort of endpoint in mind. And so I think that what I would suggest for our government, government colleagues is that we sort of know what the causal pathways are here between things like diagnosis, things like prompt entry to treatment, viral suppression. We have models that we can use to sort of ask where we are on those trajectories. And so I'm parsing my words because I'm trying to balance between our aspiration to do big things in short time frames and the realities that folks have voiced here, which is that there's not anything I think individually any of us could do to work harder, work longer, do better, that there are financial barriers, there are stigma, structural racism barriers that got planted a long time before we got in these chairs. And so I think trying to look at what the leverage points are, I think identifying, as has been raised today, where there are increases, the question about questioning the data points that we think seem implausible, identifying the ones that we think seem alarming, and really asking for these harder conversations, these more sequenced conversations about what that causal pathway is to those outcomes, how we measure and understand those, and what it means to do things equitably. I mean, that's a really, really non-answer, but I think just objectively, we're not on course. And if there was an easy answer, we'd all be pounding the table for it. So I think it's trying to break down in these sequence of things that need to happen. And I think in these processes, you can compound small improvements early on in that pipeline of getting people to a first HIV test that have implications downstream from that. So I don't think there's a very satisfying answer. It's like it's again, like the complexity of the reasons why we are where we are belies easy answers to how we're going to get there. But I think this kind of conversation, which for me is very real, and I think people have been quite frank and called out the things that don't make sense and nodded for the things that do. This is how we sort of try and quantify the hard aspects. I don't know if that's any kind of answer at all, but I think it's what I feel.
So we want to thank our panelists. This was it's tough. Data is wonderful. It's also tough. And thank you all so much for sharing and for your presentations today and your responses to questions. Before we hand the gavel back over and turn off our microphones for good, I just want to remind everyone, we have an incredibly low number of data points for trans and gender expansive people. And I believe I'm the only trans person at the table, so I would be remiss if I didn't take this opportunity to say that, because trans people are included in every single cultural, racial, and ethnic demographic when it comes to HIV risk, acquisition, treatment, care, prevention, etc. And yet we're so sorely underrepresented. I just wanted to make that point. And so encourage all of our colleagues to make sure that we're aggregating and prioritizing trans and gender expansive people in our work, as well as all of the other folks who were mentioned here today. So let's give all of our panelists a round of applause. And we'll hand the gavel back over.
And we will continue the applause for both Tori and Dr. Tukes for their expert facilitation. Thank you so much. What a thought-provoking, emotion-provoking conversation. So I do appreciate it. And to those of you who were waiting in queue, our apologies. We are tight on time for the agenda. So Casey, I saw you were up in queue and several other members. I do encourage you all to talk and continue the conversation, obviously, over our lunch break. We do have a shortened lunch break today to make space for more conversation and discussion. So I am going to ask that we all return. I'll give a 5-minute grace. If we can reconvene at 12:50, So co-facilitators, if you can be in place and on time for that, we will start sharply. So hopefully we will have most of our folks back around the table. Before folks disperse, I want to turn it over to Caroline, who hopefully will give us as members some guidance and instruction around what we will do during our lunch hour. But for everyone else, see you back at 12:50. Thank you.
Thank you, Marlene. Yes, Stephanie Tiller over there has reached out about a buffet lunch. If you did not register, but you would like to, no worries. Just let Stephanie know, and she'll get you taken care of. For everyone else, we are going to be in the Wilson and Jackson rooms, and so Stephanie and Jennifer over there will help escort folks to that conference room. So thanks. Have a great lunch.
Produced by the U.S. Department of Health and Human Services.